Okay, so moving along to what are we going to do now about the exposure, risk needs assessment and trauma? What do we need to do? So given all this research and the connections between trauma and um, criminal behavior, we need to pay attention to trauma and criminal risk needs assessments and treatment too, for that matter. Risk need responsivity model currently categorizes trauma as specific responsivity factor to assess. I'm going to take that a step further and indicate that whenever we're doing risk need responsivity assessment, it needs to be trauma informed, which I'll discuss in a minute. There's a lot of data now to suggest that current criminogenic need-focused assessments and treatments may miss the mark by addressing an outcome rather than a core disturbance. This was presented by Vitopoulos. I'm not sure if I'm saying her name right, but she talked about a trauma-impacted youth, as an example, may use drugs or alcohol to manage dysregulated emotions. But substance abuse treatment on its own may not target the underlying potential need for self-medication. This is something I think is very important, and that's that when you're doing any types of risk assessment, trauma-informed, you want to always pay attention to resilience factors, protective factors, and strengths in developing your case management plan. I have a concern that if people are too laser focused on assessing trauma alone, that could feed into a deficit model of assessment where the person has, is only listening and hearing that they have all this trauma and they're not hearing their strengths and their competencies. At this point, there's enough research to support a need for trauma-informed assessment, as I said. My experience with the risk need responsivity model is that it's data-driven and flexible, such that research findings, particularly well-constructed meta-analyses, those findings can be integrated into the model. You really want to use, just to continue what I said before about the deficit model, you really want to use the assessment to help the person write a new narrative about their life. It is important, in my opinion, to not treat the person as quote unquote different, no matter what degree of traumas have happened to them. There's Harry Stack Sullivan, who is a psychoanalyst, is known for saying, we are all more human than not. So you really want to work with the person so that they do not feed into a victim story, but rather a survivor narrative. That's what you want to help the person to develop. So working with trauma-informed assessment requires that the assessor has an awareness of the ways in which trauma can shape brain development, worldviews, and coping with stress. Trauma-informed assessments change the evaluation question from what's wrong with you to what happened to you. So how can risk need responsivity, risk needs assessments become more trauma-informed? Well, it goes back to training. The training should include different types of trauma, particularly complex trauma and its sequelae. The training should occur, in my opinion, when the person is initially trained in the instrument and should be part of those training modules. Education on the neurobiology of trauma plays an important role in the field of criminal justice, which includes redesigning information gathering, such as an assessment, to decrease any re-traumatization during the assessment. The training that I'm talking about should focus on assessing the different responses to trauma that may be displayed during an assessment, including dissociation, emotional dysregulation, and blunting of affect. I'm concerned that if people are not aware of these possible responses to trauma, that they may misunderstand or misevaluate the person's behaviors, thinking that there's something else. Now, furthermore, moving with trauma informed, I am going to borrow again from Goldenson and Brodsky and Perlin's definition that trauma-informed care understands that psychopathology often emerges in developmental contexts, and the problematic behaviors are frequently adaptations used to cope with the physical and emotional aftermath of past trauma. They posited 5 guiding principles for trauma-informed service delivery. Provide a sufficient sense of safety for the evaluation, which can be a daunting task if you're working in a prison. Being sufficiently trustworthy for the person, work together collaboratively, and provide a choice when possible to the individual, and work to empower that individual. Example is that a trauma-informed assessor should notify the individual they are assessing at the outset of the assessment that there may be questions that could cause some distress. Also, the evaluator should look for signs of distress in the individual and assist the person in dealing with any heightened arousal triggered by traumatic memories. 2 instruments that I use, and of course, the trainer for them is there are the level of service instruments, the youth level of service and the level of service for the adults. They do ask trauma-focused questions in the responsivity factor sections of these instruments. Specifically, the YLS has a series of trauma-related items about the family and the individual, and the LSCMI focuses on individual trauma history. It's important, these categories are in the non-scored responsivity sections of these 2 instruments anyway. I am unclear if assessors routinely ask these questions though, because sometimes I believe the section 1 of the level of service instruments is the priority because of the fact that they're the only scored sections. But you should be asking everything in there to develop a case management plan that's comprehensive. So moving further along with trauma-informed assessments, again, the person who's doing is doing the assessment understands that a person who has been exposed to traumas may have a quote-unquote sensitive amygdala. Frankly, I'm going to mention these these methods to assess a person, but I think they should be done with everybody anyway. At the same time, respectful and empathic approach should be used. Eye contact, unless there's cultural norms. Sometimes you may need to repeat questions or instructions if the person has gone into some retriggering of their traumatic memories. Present one question at a time and use the de-escalation techniques if the person appears agitated. Use of motivational interviewing is also important. That actually, at least in the trainings I do, is a part of the initial training in risk needs assessment. Again, I'm just kind of harkening back to the earlier slide. It's important, I believe, to look at ACEs and other forms of trauma, but you do not want to over-focus on negative events to the neglect of protective and positive factors. A focus on individual strengths and competencies is essential. So moving along to trauma assessment screening tools, Zettler in 2021 did a review of the instruments for youth, and she said that presented a UCLA PTSD reaction index, trauma symptom checklist for children, and the PTSD checklist for children / parent report were 3 instruments that were commonly used from the review. For the adults, there are a number of instruments. Dr. Wolf, she used the computerized version of the PTSD checklist or the PCL and a clinician administered PTS scale to screen for trauma in incarcerated men in a study that she published in 2015. An instrument that's out there that's been used internationally and has been translated into 27 languages is the Global Psychotrauma Screen. The argument that I'm going to make here is that it's helpful to have an instrument that differentiates between post-traumatic stress disorder and complex post-traumatic stress disorder. Currently, the DSM-5 does not do that. However, the International Classification of Disease, 11th edition, which just came out in January 2022, does differentiate. And there is a international trauma questionnaire, which is consistent with that International Classification of Diseases 11th edition presentation. It has a youth version and also an adult version. The youth version has been translated into 4 languages, and the adult version has been translated into 28 languages. There is research support for the use of both these items, and there's 1, 2, 3, 4 studies, but there's a number of ones too, that beyond them. For just a quick description, the child and adolescent version is a brief 12-item instrument that's used with individuals 7 years old to 17. The adult version is a brief 18-item measure which focuses on the core features of post-traumatic stress disorder and complex post-traumatic stress disorder. Both versions of this instrument are public domain, and they are no fee for them. On the bottom of my slide here is a way to be able to their website. So I'm going to I'm trying to make this argument that there should be some differentiation between post-traumatic stress disorder and complex post-traumatic stress disorder. Studies have shown, like Foster and Irwin, found 2 distinct groups of individuals in their prison sample, post-traumatic stress disorder and complex post-traumatic stress disorder, and they seem to have different clinical needs and risks. There is data that indicates that some people with complex post-traumatic stress may not respond initially to cognitive behavior therapy programs, as they may need a more graduated approach. In other words, they may need some neuroregulatory interventions first, which teaches them to calm down, use physical stuff like perhaps yoga or other ways to lower the overactive amygdala. Of course, cognitive behavioral therapy has a very strong record with many disorders, including post-traumatic stress. However, if someone needs a phase-in method of getting regulated first, if they don't get that, they may drop out of treatment and they may be misinterpreted as being resistant, which is not a term that I generally use. So why not use the Adverse Childhood Experiences Questionnaire just for this? Because there's a lot of data to support its in research. Well, the government, the United States federal government, as part of the First Step Act, lists the ACEs to assess the need for trauma-related services with federal prisoners. It is useful for research metrics. However, the ACEs by design is meant to capture some trauma in the first 18 years of life. The questionnaire is silent about any trauma after the age of 18. ACEs covers broad categories, but misses others, such as community violence. It does not ask questions about symptoms, and ACEs does not assess the frequency, intensity, or chronicity of exposure to adverse childhood experiences.